Doctors as a community world over are still regarded very highly and trusted upon by the people. But I think we all know that public trust is likely to wither away unless the physicians take proper steps. And in next few slides, I would be explaining why is that true. And I think that trust is already withering away. I know that we live in a society which is not the same as it was many years ago or many decades ago. And the times have changed, and we need to rethink, reevaluate ourselves in terms of medical practice. When we look at the human social behavior, I think it's governed by multiple factors. If we look at that, we have customs, traditions, we have etiquettes like professional etiquettes, courtesy, which unfortunately is going away. And then, of course, we have ethics, which is professional values, competence, fairness, truthfulness, integrity, and goodwill. But we are all governed by law as well. And I think we as professionals, physicians, need to know what are the fundamental laws which govern the medical practice. And of course, then the question of morality always arises. Now, how do we bring in ethics into all this whole scenario which I have just described? And I will go through it one by one. So what are ethics and medical ethics? I think we all know that ethics is a theory of living. In simple words, what is right and what is wrong is what ethics is all about. So what is right and correct for a medical professional will be medical ethics, if we really put it into very simple words. But I think medical ethics is a discipline that evaluates the merits, risks, and all social concerns of activities in medical practice, and it determines the conduct of health professionals, and we are all health professionals sitting here. It does not include doctors only, it's all medical professionals or health professionals, nurses, and so on. It has been at the heart of medical practice. I think medical ethics guides physicians in their relationship not only with patients but with colleagues and society as a whole. And I think we must remember that we are members of a society. And when we talk about ethical practice or other obligations as a physician, then there are certain obligations which society has towards us and we have towards the society. And I think it provides standards of behavior and decision making in medical practice. I'm sure each one of us is familiar with this picture. This is Hippocrates. We all know Hippocrates' oath, which was the fundamental foundation of medical ethics, or the first person who spoke about medical ethics in clinical practice. He's considered as one of the most outstanding figures in the history of medicine. And this is 460 BC. So this is something I think which has always been part of medical profession. In Hippocrates' oath, in 8 paragraphs, swearing the oath pledge to keep patients from harm and injustice. And I think these are the two fundamentals. If we believe in that there should be no harm to the patient and we need to be just to the patient, that actually covers the entire fundamental concept of medical ethics. Of course, the modern medical ethics this is written by Louis Lagana, who was the Dean of the School of Medical Tufts University. I shall respect the hard-won scientific gains of those physicians in whose steps I walk and gladly share such knowledge. So sharing of medical knowledge and transferring it to the next generation is part of our ethical responsibility. Of course, avoiding twin traps of over-treatment and therapeutic nihilism, very much applicable today. Unfortunately, we all know how it is being practiced. I will remember that there is an art to medicine as well as science, and warmth, sympathy, and understanding may outweigh the surgeon's knife or chemist's drug. And I will not be ashamed to say, I know not. And I think each one of us should remember that we don't know everything. And if a patient is in front of you, we must know what we are supposed to treat and what we are not supposed to treat. I will respect the privacy of my patients, confidentiality, but it may be also within my power to take life. I think this is a unique thing which is to do with the medical profession. You as a medical doctor have that ability that you can take somebody's life without being convicted. And I think that's where a lot of things come in terms of ethical practices of medical profession. I must not play God. and none of us is a God. And I think we must remember that. And of course, I will remember that I do not treat a fever chart, a cancerous growth, but a sick human being. And I think all the fundamentals which lie with the human being must be observed. I will prevent disease whenever I can. I will remember that I remain a member of society with obligations to all my fellow human beings. This is 500 years BC. These paragraphs were written by Hippocrates. And I think I do not violate this oath. May I enjoy life and art and respected when I live and remembered with affection. And that has been the historical perspective of medical profession. I think there are ethics of medical professionalism from Islamic point of view. We being as Muslims have certain obligations, and I think that's true. Medical ethics draw their essence from Islamic teachings. And I think if we really believe in that and practice that, we really do not need to remember all those things which I just mentioned, because they are part of the Islamic teachings. So what are the principles of medical ethics? And I think each one of us need to remember that. The first and foremost is beneficence, which is to act in the best interest of the patient. And I think that's the first principle of medical ethics. Non-maleficence, do no harm. And of course, I think that's one of the most important things which we highlight. Autonomy, the patient's right to refuse or choose. That is consent. And in our case, when we say pediatric patients, of course this comes from the parents or guardians. Justice. Who gets the treatment and on what merit? And I will be giving few examples where I will be asking you as what you would do if you were the treating doctor at that time. Of course, dignity, patients and doctors both have the right of dignity. But I think if you are good to the patient, you will always be dignified. There's no question about that. And of course, truthfulness and honesty. The patient deserves to know the whole truth about their illness and the treatment. And these are the fundamental principles of medical ethics. What are the difficulties in practicing or implementing these? I think by and large we have not sworn in, but that's what we practice every day. Each one of us practices that. We practice medicine in environments which are not very conducive. There is poverty, there is illiteracy. The cost of treatment is beyond means of many patients, and that obviously obstructs you, that puts you in difficult position when you are practicing as a medical professional. Of course, there are rights of patients, but then there are rights of doctors as well. We should be talking about both, not just the patient's right, but the doctor's rights as well. And unfortunately, there are no policies or failure on part of the state policy, because implementing them is a major issue. Then there are situations that we confront in clinical practice. Of course, they are at reception communication. That medical examination can be in a clinic or an OPD setting, in the wards, in theaters, or in terms of treatment options. Do we really take consent from patient when we are installing any treatment which is not the usual one? Ventilatory support, cost of treatment, legal issues, research, cloning, family planning, abortion, organ transplant, blood donation, and so on. So there are many situations and difficulties which come across in practice as a physician. But I think when we talk about pediatric care, it's a branch of bioethics, obviously, that analyzes moral aspects of decisions as a carer of children. Now, pediatrician is different from a physician. The reason for that is that you are not only treating the patient, you are treating the entire family. And when it comes to family, you are treating the parents, the relatives, and the community at large. And I think that's why it differentiates a physician from a pediatrician. Pediatrician has a different personality. You can tell this is a pediatrician and this is an adult physician, because they look different as well. After a while, they start looking the same, because pediatricians become more humble, they are more sort of considerate, they somehow become more empathic as well, because they deal with children. And I think that fact actually puts you in a different league than an adult physician. Decision making for children is a unique and challenging process, and I think adults make their own decision. Here, the adults don't make their decision. Here the parents are making the decision. But how would the parents make a decision? It's what you tell them. You as a physician, you tell them. But I think we must admit now that this is a word of social media. And we have many Google doctors as well. And when the parents come to you and talk to you, they normally have gone through many things already. So then you have an ethical dilemma as what is correct and how do you interpret their perception and how do you correct their perception becomes extremely important. And I think not only the parents, family members, I think we should involve nursing team and other related professions to make a decision. Beneficence obviously is the foundation of decision making, but how would you do that in a pediatric practice? Because pediatric practice is different from an adult practice. And I think what I will do is I will be showing you few case scenarios as to make a decision what is the child's primary caregiver. Parents give informed consent by proxy. Is it really a consent or a permission? To my mind, it's a permission. Because consent has to be by the person who is being treated. So parents are actually giving permission that you can treat their child. So the context of beneficence in pediatric practice is different from an adult practice. Rights versus responsibilities. And I think there would be many ethical dilemmas in clinical practice where we have to differentiate as what is right of the patient and what is the responsibility of the doctor. And if there is a confrontation or if there is a dispute between the two, how are you going to resolve that? Because the parents can get very aggressive. And if they become aggressive and they want to have something done, as how, as a doctor, you are going to treat them. And I think rights can be exercised. You have rights as a doctor, but I think at the end of the day, it's parents. It's their child, and that decision or their permission has to be weighed higher. Do no harm. Is living with a severe impairment versus death? How do you decide that? You have a child who is severely incapacitated. And I think we have people sitting here from developmental pediatrics, from neurology, and so on. And we know that there are many children who cannot be helped. There is no long-term outcome. And you give a vegetative child to a parent, and you have done with their rest of the life because they would be looking after that child for rest of their lives. So that ethical dilemma sometimes has to be discussed, deliberated, and fully informed the parents in terms of decision making. Who should decide? Best interest? Is it on ethics of protection? And of course, then comes the neglect and abuse, which can be on part of the parents as well. Justice. I think I've given one scenario of immunization. I'm sure each pediatrician faces that. How do you convince sometimes the parents that your child needs to be immunized? And I think we have seen killing of medical professionals when they went for installing polio drops across the country. Now, how do you defend that? You are doing it in the best interest of the patient, of the child, and if the parents do not want their child to be given polio drops, how do you deal with that? I think this is something which is again an ethical dilemma, and I think that justice challenges the absolute sovereignty of beneficence. And I think this is something which has to be looked into it. End of life issues. We as pediatricians, pediatric super specialists face that every day. And that's particularly true for people working in hospitals. And that too in hospitals which are tertiary care hospitals or quaternary care hospitals, because most people die there. End of life situation arises in the hospital because that's where you are actually dealing with them. And the parents come in with lot of hopes. They have been given false assurances, and once you deal with them, it becomes really an issue. Withholding and withdrawing support becomes a major ethical dilemma. You talk to people working in ICUs, whether it's cardiac ICU, surgical ICU, medical ICU or neonatal ICU, a child with birth asphyxia, grade 4, being ventilated for 10 days, 15 days. Genetic testing. This has become very popular in our country too. And I think this is again something we as pediatricians need to be extremely careful. We must be very clear in our mind as what we are going to get out of it. We live in a society where illiteracy is still very high, and we may lead to something which is of no benefit but can actually be a major social dilemma. So I think extremely care needs to be taken into such cases. I put you 3-4 cases before I finish and would request you to answer me. I'm putting case 1, and this is a true case. One of the postgraduate residents comes to me in my office and says, "Sir, I'm working in so-and-so department. I have a colleague who has been trained, unfortunately, overseas. I'm extremely worried about his clinical competence, and I think that he's actually dangerous to the patients. And I've seen on a couple of occasions that if I would not have supported him or somebody would not have gone with him, he could have harmed the child." Now, this is whistleblowing. This is that your colleague is telling somebody senior that you have a colleague who already, although registered with Pakistan Medical and Dental Council, has also passed the required requisite examination, but is not safe physician. How do you deal with that? What would you do? Anyone? So, one is remedial measure, that you do not let him do an independent duty. You attach him with somebody and see how he progresses in next 2 to 3 months. 3 months down the line, that's what exactly I did. 3 months down the line, the supervisor who was with him comes to me and says, "Sir, the person is not trainable. I don't know how did he get into medical profession. I've been watching him, teaching him, training him, observing him for last 3 months, and I think he is still dangerous to the patients." Administrative side pe laga de. That's what we did next. We took him out of that, but then he's a postgraduate trainee who has passed as part 1. He had passed his MD CAT or whatever, जो आपका जो MD का student था, उसने अपना exam भी pass किया हुआ था, and then we didn't know what to do next. Because you can't really put him to an administrative duty because he's a postgraduate resident. Enter into the system. But now he's part of the system.
Right now is only addressing the problem, which is the person himself. This person has gone through a training program, has gone through a vetting program.
This was his year 1. This was his year 1.
But he's still gone through a vetting before he was selected.
Absolutely.
There. So we also need to not just focus on the person himself. We also need to look at our own system, whether it is good enough, how is it allowing such a practitioner to come into this system.
Thank you very much for highlighting that. Because this is what I was coming to. I think we have people like, to my extreme left is the ex-chair of the, or ex-president of Pakistan Medical Commission, and really we would like to hear from him at some stage. I think he has the next talk as well, as how are we going to go about this system of our undergraduate training. This entire scenario actually is highlighting the fundamental problem as where are we leading to in terms of our undergraduate medical education, creating such ethical dilemmas in real practice. End of life. A 10-year-old admitted in ICU through a private adult hospital. The child walked to a private hospital. These are all real scenarios. Walked to a private hospital, had tonsillectomy done, arrested during tonsillectomy, had CPR for 30 minutes, was then kept into that hospital. Somehow they managed to shift that patient on ambu bagging to a public sector institution, where on the way he arrested again, was resuscitated. By the time he came to the hospital, had another resuscitation, and is in ICU now, ventilated, and 4 weeks have already gone. The patient is brain dead. Parents refuse to accept and rather become extremely aggressive if you tell them that we are considering termination of care or end of life context. What do you do? Now, there are 3 aspects here. The person who did tonsillectomy in a private hospital, should he have done it in a setup where there was no adequate facilities, no adequate intensive care, no adequate anesthesia cover, and then transferring a patient without a proper appropriate support to a tertiary care hospital, no proper coverage, he arrested during the way, and then you end up in a ICU where the patient is being ventilated now for last 4 weeks. What do you do? This actually illustrates the fundamental flaws in our system. And that medical system, I think, needs a very careful re-evaluation and seeing how we are going to go from here onwards. We are working as a consultant. I'm working, this is my personal scenario, I'm putting it to you. I'm working as a cardiologist at Children's Hospital. We are seeing hundreds of patients every day, and almost 20 to 30 of them need surgery on daily. I'm talking about day, not week. So only 5 of them can be put to surgery for one day because we have 3 operation theaters and there's an intensive care which is only 15 bedded. How will you decide? Now I put you in a scenario, 4 infants with VSD, pulmonary hypertension, 2 children spelling, have tetralogy, may die if we don't operate, 1 child with tricuspid atresia, only male child, only child of the parents, and the parents are already in their late 30s. 1 child with transposition, and a medical colleague, a professor has requested, because it is from his family, to put him on the list. And 1 child with TAPVC, the health minister has requested to put on the list. This is a real scenario. Only 5 of them can be put on list. Please let me know which ones you would put. Yes, that's what I was coming to. Every child has a right to treatment. Now, as a professional, do I have a right to select 5 out of these 7 or 8 patients? And who gives me this right? This is distributive justice. That you look at your setup, you look at your system, what you can do and what we can do. So which ones would you go for? The ones who have the best outcome. You think, who will get out of my ICU quicker? Who will get better in one surgery, and who has the excellent prognosis in the long term? A 35-weeker maternal UTI, weak hypotonic from birth, X-linked myotubular myopathy on diagnosis, age 6 months, unable to swallow, reflux, nasoduodenal tube, oxygen dependent, regular suctioning, parents refuse any surgery and do not want to take him home. So he's your child, he's your patient, he's in your hospital. You have put in a lot of resources, you have put in a lot of effort to bring that child to that stage. So what do? It's an ethical dilemma. I think what is in baby's best interest, beneficence, non-maleficence, versus parental autonomy, they do not want to take the child home, and distributive justice. That I work in a hospital which is a public sector, it's a public owned money. Am I treating this child, or should I be taking another child who has an excellent prognosis, will get home in 5 days, 6 days, or I keep this child in the hospital till I can convince the parents to take him home. So I think when a life-saving situation arises, what are the issues? Brain death, vegetative state, no chance, no hope of survival, no purpose, unbearable. These are the fundamental things which we look at as an intensivist or caregiver in a scenario like that. I would stop here by concluding that I think there are 4 fundamental principles that serve us as medical ethics, and these are respect for autonomy, beneficence, non-maleficence, and of course justice. We must identify individual ethical dilemmas, establish the necessary information, analyze that information, and formulate possible solutions, make recommendations, and take actions. We have to take actions. If we do not take actions, let me tell you that tonsillectomy child, we wrote to the Pakistan Medical and Dental Council. We wrote to that hospital. We involved the other people as well, because we thought it was extremely unfair to the parents, to the child. If they did not have that facility of appropriate care in a hospital which was not fully equipped and did not have the adequate human resource, why in the first place they actually did the surgery in that setup? And of course, they serve as a point of departure and reference, but need to be weighed and balanced. In the end, we must come to a decision which may not be perfect, but we must be able to supply our reasons and motivate them clearly and coherently. Therefore, all of us must become ethically sensitized and take responsibility of our decisions.